tear, it falls and hits the ground. A tree, it falls without a sound. A bird, it calls and sends you home. A man, he sits in the cold all alone.
Hi, Jessica. Welcome to the Joy of Sunflowers. It's so great to have you on here. Please introduce yourself to everyone and let us know about you.
Hi, Ella. Thank you for having me. My name is Jessica. I'm an embryologist in the United States. I've been an embryologist since 2018, and I also recently started an Instagram page and blog called Explaining IVF, where I help educate people about the various aspects of IVF and infertility.
Wonderful. I found a lot of use in your page because I don't know much about IVF, and it's very interesting to actually see some information. And I do think it's really helpful. And the way you do it as well, like there's kind of a little bit of humor every now and then as well, which kind of like makes it a bit nicer because obviously going through infertility, going through loss, like it's all quite intense. Having a little bit of humor just kind of eases the mind a little bit.
Absolutely. Yes, I did notice there was a big knowledge gap in a lot of the patients that I saw when I was working at the clinics. And so I figured that this was a good way to educate people because a lot of people were coming into their cycles having questions that really should have been answered before they even started. So I'm hoping that they can use this as a tool to see accurate images and get accurate information before they go into their cycles to hopefully make better decisions while they're in their cycles. And the humor does help. I wasn't sure at first how people would react to it because you're right, it is a very sensitive topic, and I really do appreciate the sensitivity of it, but people actually really do enjoy the humor. So I guess, we kind of needed that a little bit.
I think so. And it's just, I mean, it can be so awful to be in this space, but then it can also be really beautiful and kind of like character building as well. And I think there's a real camaraderie in it. So yeah, comedy just kind of lightens the mood and can just kind of bring you out of that like misery headspace and kind of bring you into like, okay, yes, this is hard and we're doing this hard thing together. We're not alone in it. And we've got this camaraderie because we've got this, like, we've got these comedy joke things that we can all relate to. So
Yeah. Absolutely. I have never seen a community as, supportive and as informative and knowledgeable as the IVF community, both in the educators, the workers, but also in the people going through it. I mean, there are so many people who are so proud of other people who are doing well when maybe they're not, but it's just so supportive. Or if someone has a question, people are always just so quick to be like, well, let me help you. What can I do to help you? I've been in this situation. Here's something you can do. I've never seen a community as strong and as supportive as this community, and I love it.
it's amazing. When I entered the space, I obviously didn't know it existed until I had a loss. And it was just so amazing to me because there was just all these amazing women just like coming together and really supporting each other. And there's even some men in the space as well that can also be really helpful, just to like ease our minds about our own like partners and like because sometimes they don't cope or they do things differently. And I think, yeah, it's just been really fantastic to see that. So first off, just to start off, before we get into the sort of process of IVF, you said about people knowing what to do to sort of set up. So, like, what things would you need to know sort of before you go into the process of IVF?
I think it's important to know the definition of infertility. I think that a lot of people think that, they've been trying for maybe a couple of months and they can't get pregnant. Well, that's not always abnormal. So that doesn't necessarily mean that there's an underlying issue if you've been trying to get pregnant for a few months and it doesn't work. So I think it's good to set your expectations that you might go into a fertility clinic and say, hey, we've been trying for a couple months. And they might just say, keep trying, come back, and we'll work on something. And that doesn't necessarily mean that you're going to jump right into IVF. There could be other options available as well. But the main thing is finding out what is causing you to not be able to get pregnant. Is it something that would require IVF, or is it something that maybe is a hormonal imbalance? Are your tubes blocked, in which case you probably would need IVF? Is there a surgery that you need? What's your diagnosis? So there are a lot of diagnostic tests that you can do that can kind of help decide the best path whenever you are seeking help for infertility. Once you kind of meet that criteria as being infertile, there are some tests such as an HSG. That's a hysterossalpingogram, which is sort of like an x-ray of the uterus and the fallopian tubes. It can tell if there are any blockages. So that can help determine, what course of treatment would be best for you. Or something like a hysteroscopy, which is a scope that kind of goes into the uterus and looks at the lining, because maybe you have a polyp or a fibroid or some scarring. And so then, maybe we need to get that taken care of before we try to get pregnant, because that could be interfering with what's happening. So I think those are a lot of the big things, is knowing exactly what you're going in for. And sometimes people don't know. Sometimes you find out in the process, and unfortunately, some people don't find out at all. It goes into the category of unexplained infertility. But I think that setting yourself up for the expectations, knowing that it could be a prolonged process, it does, just because you go into an IVF clinic just because you go into a fertility clinic does not mean necessarily that you're going to start IVF right away and that you could, perhaps be pregnant within a couple of months. It's a prolonged process.
Yeah, I think like including myself, so many women kind of think, oh, well, if we can't get pregnant, we'll just do IVF. Like we'll just do IVF, and
Yeah.
so like from everything I've seen, it's not like that. It's not that simple. And you don't even think about all the testing to like see if you are infertile or what's going on, because I think a lot of women are just like, no, I'm infertile. It's been so many months. I've tried this long and I couldn't possibly get pregnant. But yeah, there are odd things that can be happening, within you, and then you do get pregnant, and then you're like, oh.
Right. Right. And sometimes, you think and you're like, you want to get pregnant, you want to do IVF, but then do you want to spend the time, the money, the stress, everything that comes along with IVF when you don't necessarily need it? So it's a double-sided coin. IVF definitely helps people, but it is a process. So, which I know we'll talk about, but you're right. There's a lot more that goes into it than just, I'll go to the doctor and we'll do IVF and everything will be great.
Well, let's go into that process, because obviously I know it's quite a prolonged process. Let's just go through like what's involved in sort of one cycle, one lot of IVF.
Sure. Right. So a basic IVF cycle would actually begin whenever you start your period for the month. So it kind of goes off of your menstrual cycle, but the timing can also be controlled with medications. So the first thing that you will do is something called stimulation. And stimulation just refers to administering medications that do two things. They'll help multiple eggs inside of your ovaries mature, and they'll help ovulation from occurring too soon. So they can control the timing of ovulation. So it's important that the eggs inside of the ovaries mature, because you want to have mature eggs retrieved. If they're not mature, unfortunately, they can't be inseminated. They won't grow into embryos. So it's important that you have hopefully multiple eggs that have matured by the time of the egg retrieval. And that can be monitored with an ultrasound. So they can look at those follicles in the ovaries, and they can measure them on the ultrasound to help estimate if the eggs inside are mature or not. And the second medication, again, it prevents premature ovulation from occurring, because what would happen if ovulation occurred too early is the eggs would not be able to be retrieved. They would be lost.
Wow.
So, yes. So that's the first step. Once your follicles reach a certain level and your hormone levels look okay, your doctor will have you administer what's called a trigger injection. And this will trigger ovulation to occur about maybe 40-ish hours later. So your egg retrieval will actually be scheduled right before ovulation should occur. So again, it prevents those eggs from being ovulated so they can be retrieved from the ovaries. So that's the first step. And then at a scheduled time, you'll come in and you'll have your egg retrieval. So I know in a lot of cases, this is performed under sedation. And what happens is the doctor will take a needle into each follicle in the ovaries, and they'll use a vacuum pressure to actually aspirate or suck up the fluid from inside of the follicles. And the hope is that in that fluid, there are eggs. So in each follicle, there should be an egg. It's not always the case. There are things called empty follicles, meaning that a follicle grows, but no egg comes out of it for one reason or another. But the hope is that in each of the follicles that are aspirated, there is one mature egg in it. So during the process, the fluid will move through the needle, through a catheter, and into a tube. From there, the tube will go into the IVF lab where an embryologist will look at it under a microscope, and they'll sift through the fluid and they'll find any eggs. So any eggs that are found will get isolated into a separate dish. The rest of the fluid is disposed of. We don't need that anymore. The next step would be to clean the eggs. So if you're doing something called ICSI, which we'll talk about in a minute, the eggs will be cleaned and graded. If not, the eggs will not be cleaned and graded. So one little minor difference between the two processes. But if you're doing ICSI, which a lot of people do, the eggs will be cleaned with an enzyme and they'll be graded to make sure that they're mature. So again, only mature eggs can be properly fertilized. So any eggs that are not mature at the time of ICSI will be discarded. For the other type of insemination, they're not cleaned or graded. So any eggs that are retrieved go into a drop of media with sperm, and they're allowed to co-culture overnight where hopefully insemination occurs. But if you do ICSI on the same day as the retrieval, you'll take a sperm sample, and you'll pick sperm that are normal in appearance and are moving normally, and you'll actually suck those sperm up into a little needle, and you'll put one sperm in each mature egg. And then the following day, whether you're doing ICSI or the standard insemination, you'll check those eggs to see if they properly fertilized. If they did, they get to move on in the process. If not, unfortunately, they're typically discarded.
Oh, wow.
And from there, so from there, you wait a couple of days, and some clinics will look at the embryos over the next couple of days, but most clinics will wait until 5 days after the egg retrieval. So that's called day 5. And that's when a fresh embryo transfer can occur. So that means that an embryo is taken into a catheter and is injected into a woman's uterus using an ultrasound as a guide. The embryos can also be biopsied for pre-implantation genetic testing, or PGT, which is where they look at the chromosomes and the DNA to decide if there are any abnormalities. Or the embryos can be frozen for future use, which is where they're coated in a cryoprotectant and they're placed in liquid nitrogen so that they can be hopefully transferred in a future cycle.
Yeah, we have a lady who's doing that at the moment. She's like trying to save as many eggs as she can. So yeah, that's interesting.
Yeah. And some clinics will culture embryos on up till day 7. Some will culture to day 6. I think most clinics culture to about day 6. And then from there, the embryos, any that continue to grow, can be biopsied and or frozen.
Yeah, that's it's amazing what we can do now, isn't it? Like, gosh, so many things. Are there any factors that kind of change what sort of insemination type you're going through?
There are. So, and that typically deals with the sperm for the most part. So if you have something called male factor infertility, or MFI, that means that you have something that is something male related that is causing the infertility. So an example might be a low sperm count or a low motility. It could be that the sperm, a lot of them are abnormal in appearance. In those cases, it's typically indicated to do ICSI. And it's only because for ICSI, you only need enough good sperm to fertilize each mature egg. For conventional insemination, you need a lot more sperm. So I don't know the exact number, but you need to have a really good concentration of sperm in order for the conventional insemination to be successful. So that would be the number one cause. Another reason might be if you've tried conventional insemination in the past and it failed for any reason, your doctor might say, well, let's try ICSI, because overall ICSI does tend to yield better results, especially when there's any kind of male factor issue.
So is ICSI is where you put it straight into the egg, right?
Right. Yeah. So you'll suck a sperm up into the needle and inject that sperm with that needle into the egg.
Right. And the other one's sort of more natural, like in a tube thing, and then they do their thing, hopefully, and one goes.
Pretty much, yes. They're put together in a drop of media overnight. And yes, we hope that in that time, the sperm will inseminate the eggs. And a lot of times they do, but there are cases where they just don't for one reason or another.
Yeah. I'm guessing there's a price difference, and I'm guessing that's why. Yeah.
There's definitely a price difference when it comes to ICSI. I'm sure it's more expensive. I couldn't tell you right off the bat, but I would imagine that it's more expensive, and it does bring more risks because you are doing more manipulation to the eggs. So there is that chance that the eggs could be damaged, or that maybe fertilization doesn't occur properly. But overall, it still does tend to yield better results. So a lot of clinics strictly prefer doing ICSI on everyone.
Oh, wow. Okay. A lot of women obviously worry about sort of the pain and the different hormone injections and stuff as well. Does that come in from the beginning?
Yes. So the injections, that will all happen before the egg retrieval even takes place. So whenever the embryos are in the lab, you really won't actually take medications unless you're doing a fresh transfer. So your medications can actually stop before the egg retrieval even occurs. And then you would maybe do medications in a later cycle if you were doing a frozen transfer. But yes, I've heard that they can be quite painful and can leave some bruising. A lot of people have recommended using maybe a numbing spray or a cold or hot pack to kind of help alleviate that pain. And some people also use what are called auto injectors, and they say that helps as well.
I've seen a lot of videos and like pictures of women sort of putting the needles in, and I'm like, gosh, like I do not like needles. So it's sort of I'm like, wow, you're a brave, amazing woman, because I just can't even face needles, like even just getting blood taken. So yeah, to me it's just amazing, and I know that there's so many involved in the IVF process. So we were just talking about sort of the initial kind of like the first process where you're sort of getting the egg and you're gonna put the egg with the sperm. So where do we go from there?
Transfer is the ultimate goal. So the ultimate goal is to get those embryos into the uterus to hopefully establish a pregnancy. But there are times when a fresh embryo transfer, a fresh embryo meaning that it has not been frozen. It's, it's just been retrieved a couple of days ago, basically. So that's that is one of the options. Oh, there are reasons why people can't have fresh transfers. And a lot of the times it has to do with the hormone levels. So especially in women who have a lot of eggs that are retrieved, they might have high hormone levels. And so you don't want to do a fresh transfer because it can cause something that's called ovarian hyperstimulation syndrome. And that can be, it can be a very serious condition. So if your hormone levels are above a certain amount on the day of your retrieval and you are planning to do a fresh embryo transfer, it will probably be canceled for your safety. And the embryos instead will be frozen. And then in a future cycle, they can be thawed and transferred.
Okay, so then you have to wait another cycle. It's not like you can wait a week or so. You have to wait a whole cycle. And another cycle is just a month. Is that right?
It usually is. Some clinics do prefer that you take a month off. It gives your body time to rest and reset. And one thing that I'm sure we'll talk about in a little bit is if you do the pre-implantation genetic testing, if you do test for your embryos for any genetic conditions, those results can take 2 to 3 weeks to come back anyway. So you don't necessarily want to start a new cycle until you get those results back. Some people do. So some people will start with the following menstrual cycle, but I know a lot of clinics like to wait to give you, like I said, give your body time to reset before you give yourself more medications, more hormones, and it also gives you time to get those results back.
Yeah, and I'm guessing obviously that will impact your actual results in terms of getting what you want at the end.
Exactly, right. And if you only have one embryo you're able to send off for testing, then you kind of looking at almost like a 50-50 chance, does it come back normal or not? And then why start a cycle if that embryo doesn't come back as normal? Unfortunately, at that point, it wouldn't be transferred.
As we're talking about the embryo stage, how many embryos do you guys like to kind of move forward with?
I think that depends a lot on what the patient's personal goals are. So if a patient wants to have, if they want to have multiple children, then you want to have at least that many embryos, if not more, because as much as you hope that every transfer will be successful, there are reasons why transfers might not work. Or if you're doing the testing and maybe you want to have 2 or 3 kids, you want to hopefully have more embryos than that because they might not all come back as genetically normal. So I would always say whatever your personal goals are, always try to have maybe an extra 2 to 3 embryos. And that's just in case for a failed cycle, maybe they're not genetically normal. And it just gives you, it's called banking, but it gives you embryos basically if you need them in the future.
So moving on from the embryo, So if you can get inseminated, that's if your hormones are either low or like at the right level. And if they're too high, they get frozen. So where do we go from there? So if you were able to be inseminated properly and you have had the embryo placed inside of you, where do we go from there?
So insemination can occur regardless of the hormone levels. So insemination can, yeah. So that's pretty much a guarantee. It's the transfer that might be canceled. And the reason is because you have to take more hormones for a transfer to help your uterine lining thicken. And so if you're taking more hormones, but you already have high hormone levels, it can actually cause some damage to your body. So the fresh embryo transfer might be canceled, but insemination will still occur. So you can still inseminate the eggs. You can still let the embryos grow. Just instead of doing a transfer, you would just freeze them instead.
So we're at the stage where we've transferred then. So where do we go from the transfer?
So from the embryo transfer, most clinics will have you wait about 10 to 12 days, and then they'll have you come back into the clinic and you'll do a blood test for what's called a beta HCG. HCG is human chorionic gonadotropin, and that's the hormone that is secreted by cells in the placenta. So if you have a high enough level of HCG in your blood, it means that implantation has occurred, because that's where the placenta comes from, is from the implantation. Those cells, as they begin to divide, that level of HCG starts to rise, and you're hoping to see about a double in the value every 2 days. So every other day, you're hoping to see about a double value for the HCG. But if you come back in 10 to 12 days and that number is really low, maybe say like less than 5, if not more, but we'll say 5 just for reference, that normally means that implantation has not occurred, unfortunately. But from there, if the numbers do come back as positive, the clinic will typically have you come back in about 2 to 3 days, and they'll do a repeat blood test to make sure that the levels are doubling. Some clinics will even have you come in for a third test just to make sure the levels are continuing to double. And then from there, you'll schedule your first ultrasound, assuming that the levels are moving in the appropriate direction. So the ultrasound will then be scheduled, and that's normally, I can't remember exactly when that would occur, but when it does, assuming that everything has gone well, you should be able to see what's called a gestational sac inside of the uterus. And it kind of just looks like a little black hole inside of the uterus. And that's the sac that will become the amniotic sac, where the baby will form and everything. From there, if everything goes well, you'll come back again for another ultrasound. At that point, you'll be able to see a little bit more. You might be able to get a measurement of the fetus at that point. And I don't know exactly when you'll be able to hear the heartbeat, if there is one. It might be at that meeting, at that appointment. If not, they'll have you come back for a third appointment. And normally that's when they can start to hear the heartbeat. Maybe you'll see the little flicker on the screen. After that, and then they'll release you to your
Yes,
OBGYN.
the first one is the sac, and then the second one you might hear the heartbeat. Yeah, because usually when you hear heartbeat, it's like 6 weeks. So
I think so, yes. I hate to say that, because there are like circumstances where even at that time it might be too early. So I don't like to give people false hope. But yes, normally at that point you should be able to hear something. But even if you don't at that point, that doesn't necessarily mean something is wrong. It just means you might have to wait a couple more days.
I've heard some clinics don't allow you at that point. Sometimes it's like 2 weeks later, just because they're unsure about what it's going to sound like in terms of like, regular and everything, and so they wait a couple more weeks, and then they're like, okay, now you can hear the baby. So we've gotten to that point. We've done the testing. Gosh, you guys do a lot of testing. You guys really keep an eye on your patient. I guess it's because you have to monitor everything, because you're doing a controlled kind of, or as controlled as possible, pregnancy to make it happen. Gosh, yes, lots of monitoring.
Yes, lots of monitoring. And it helps the patients too, I think. I think that at that point, you've waited 2 weeks just to even get that first blood test after your transfer. They call it the 2-week wait. And it's like the dreaded 2-week wait. I mean, you're waiting all that time. So I think it also helps, them to be able to come in every so often for a checkup. It's a little more than it would be if you were to get pregnant the like quote natural way. But I think it helps with some peace of mind as well. So I think it's a win-win.
Definitely. I know a lot of women, I mean, especially if you've been through infertility or you've lost babies, it's you just worry all the time. So getting those little tests and stuff just, yeah, it gives you peace of mind. You're so right. Do you stay with your one patient, or do you kind of just do a certain task and then hand them off?
So for the lab work, it really depends how many people are working in the lab. So at the lab that I worked at for the longest time, there were 3 to 4 of us at a normal time. So in a day, it might be one person doing retrievals, one person doing ICSIs, one person doing transfers. So I wouldn't say that we stay with the same patient, but at least, where I was working, we were able to keep up with all the patients. So it was small enough that I could keep track of, how many eggs fertilized for a certain patient, how many embryos developed for a certain patient, but I wasn't able to do every step for every patient.
Mm. But I'm guessing for the patient, it's probably like familiar faces because there was only sort of 3 or 4 of you as well. So it wasn't too.
Right.
Yeah.
And that would depend on the clinic as well. So
Yeah.
there are some clinics where there maybe only is one embryologist and they're doing everything. So that's very, very small clinics, very, very focused. But then you have other clinics that are doing 1,000 some cycles a year where maybe they're, and in some of the bigger cities, there are some clinics that do a lot more than that. So I've never worked in a clinic like that, so I can't speak personally, but I imagine that it might be a little bit more difficult for them to do so much with one patient or to be very familiar with them. It could be possible, but it's a lot, so I don't know.
Yeah, I mean, I know what the process of like having a baby, like being pregnant, like going through midwives and stuff and having lots of different midwives, and it can be quite off-putting. Like having one midwife is quite nice because then you just have the one that you just continually go to. So I was just sort of thinking that must be the same for IVF as well. Like it's nice to see the same face if you're in a clinic, but I suppose you just got to go with what you can go with to make sure you get what you want at the end.
And I do think that, at least in most clinics, I think that patients will see the same doctor, or maybe they'll see the same nurse or something. So at least on the clinical side, they should have a lot of familiar faces. I think that the IVF, the embryologists sometimes also are kind of the people behind the curtain. So even if we do, contact the patients and we talk with them, I don't want to say that we're not as important, but they're more focused on their doctor and having the nurse and having those kind of familiar faces. So that I would say is normal in most clinics, is to follow the same doctor or nurse or, mid-level like a PA or something through.
Yeah, that's wonderful. I mean, having a familiar face and everything. And yeah, I mean, you guys obviously are really important because you're the whole reason why this is all able to happen. You're a big part of the process. You're making babies. Um, so yeah, but yeah, that's really cool. And I like that you sort of you hopefully would have sort of the same doctor that for most of the way through, because it just
Right.
yeah, it's obviously quite a stressful process to have the same person. Probably is quite like nice and just helpful in terms of like keeping you on an even keel, especially if they're sort of, they're seeing you and they're seeing sort of how you're going emotionally.
Mm-hmm.
But
And they
yeah.
know your history. Every patient is so different. So it's good to have a doctor who knows your history instead of having someone come in who maybe doesn't know one little thing about you, or, isn't maybe something that isn't in your chart, like maybe some fun fact about you. It's good to have, a doctor that you can have that conversation with and who really knows more about you. It's like you
Yeah.
said, a familiar face.
Yeah, I'm guessing like with the charts, they're very just medical orientated. You're not really going to get much information on an individual level of each person. Is that correct?
I think that would also depend on how busy the clinic is, how many patients a doctor sees in a day and everything. For some clinics that are really busy, maybe not, maybe it's more professional, more.
Yeah.
But there might be, some smaller clinics where you get to know your doctor and, have conversations with them. There really is such a range with the clinics in terms of how many patients they see, the patient to doctor ratio, how many procedures they do. So I think you could see any of those.
Yeah. And do you get the charts? Like, do you get the medical charts when you're doing the inseminations and things?
We do, yes. And I think I could speak for most clinics when the chart normally will indicate the patient's diagnosis or the couple's diagnosis, whatever the cause may be. It will also say their their ultrasound readings. So it kind of gives you an idea of how many follicles the patient has, so you know how many to maybe expect to have retrieved or how many are to be mature. It could also give you the hormone levels, so you can have an idea of what the hormone levels look like. And then on the day of the insemination, whether the sperm sample is fresh or frozen, there will be some kind of analysis done to make sure that there is sperm, that it's there, it's moving. And so you know before you even get the sperm sample kind of what that looks like. It gives you an idea of what you're dealing with.
Once you've got the embryos, and you said, you know, you want more embryos than you want children, so you've got that sort of extra because some of them might not happen. Mm-hmm. Is there an amount that you want to be transferring into the womb, or do you just do one?
It's recommended to only do one, and there are a couple of reasons for that. So the main reason is because if you transfer more than one embryo, you run a pretty high risk of having a high order pregnancy, and that means a pregnancy of twins, triplets, or even more, because first, both could implant. Second, embryos can split. And embryo splitting is something that it happens naturally. That's how we get identical twins. But it also happens a little bit more with IVF. And we're not entirely sure why, but it has been proven that it's more likely that you'll have twins if you do IVF than you would through natural conception, basically. So even if say you transfer even just one embryo, you do run the risk of that embryo splitting and having twins. But if you transfer two, well, then you run the risk of having both embryos implant. And then if a splitting occurs, you can end up with triplets or quadruplets or more. And the problem with that is that it poses a risk to both the woman carrying the babies and the babies themselves. So risks like preterm birth, pregnancy complications, neonatal complications, so things like that. So that's the primary reason why we only like to transfer one at a time. And then the other reason is that if you have those embryos and for any reason or another the cycle fails, then you've lost two embryos when you could have lost one, if that makes sense. You never want the cycle to fail, but it does happen. And then it would be awful for not only for the cycle to fail, but to lose two embryos and to have less stored for a future try than you would have before.
Yeah, and I'm guessing like sometimes the things that can go wrong are hormonal or just kind of like maybe even diet or like just life situation, like things going on, and maybe you've missed a few of the injections or something strange like that.
Right.
Yeah. So when that happens, you're right. You lose two embryos instead of just the one, which would be pretty heartbreaking, probably.
It would.
Yeah, I saw it was a long time ago, but I saw a case of a lady, and I'm pretty sure it was IVF, and she ended up with like octuplets, like 8 babies, and I was like, how would you physically even do that?
Right. Yes.
Yeah. And she had a lot of doctors obviously in her delivery room, and obviously she had them all prematurely because I mean twins most normally are born prematurely anyway, but with 8 it was even more so. And yeah, she obviously had like a team working on each baby, and yeah, it was a pretty full-on story, and it went viral like everywhere.
And yeah, I think that's probably one of the reasons why the insurance companies, at least I know in America with the insurance companies, they really don't like when you transfer more than one embryo. And that's probably why. I mean, think of all the care that not only that mother needed, but all of those babies as well. And really, why put 8 embryos in if that were the case? You know, why put 8 embryos into one person when you have a good success rate with 1, maybe 2 most. So I think that the insurance companies have really cracked down on that because we don't want women having 8 babies at a time.
If we're being honest, like it's not actually a healthy thing. Many babies is just like, I mean, carrying 1, it can be enough of a toll. Carrying 2 can also be hard, 3, 4, you know, and as soon as you get past 4, like it's I've seen some full-on stories and birth stories, and it is so much more intense, and you end up with more likely having to have C-sections and things like that as well. So it's not you know, you lose a lot of options and choices just through the fact you have multiple. Just thought I had to bring that up because it was just such a story. And
I remember that.
Yeah, and I know a lot of women are like, oh, can't we just do multiple eggs? And I know there's a lot of women who are very like, I just want to have a baby. So have you ever had any women who are like, I want multiple eggs right now, and have you had to cater to that, or is it very strict, like you just don't do it?
It's pretty strict. It's a pretty strict, we can only do one. And again, that's insurance based, meaning that clinics can actually be penalized for doing too many multiple transfers. But there are situations that do warrant having multiple embryos transferred. And maybe in people who've had recurrent implantation failure, meaning that they've gone through multiple transfers with good quality embryos and they're still not getting pregnant, that might be a situation where the doctor would say, let's try two. Maybe in cases where you have two poor quality embryos that maybe have a lesser chance of implantation, maybe the doctor might say we can do two poor quality embryos and see if that, increases our chances. Really, the studies really show that transferring two doesn't really increase your chance of success greatly. It really just increases your chance of multiple pregnancies greatly.
So it's not you're not really getting much benefit in terms of making it happen then.
Right. I know a lot of success stories when people transfer two embryos. So it's definitely a good possibility for people, but I just don't know that it's always necessary, even especially if it's your first transfer.
Because you don't know what to expect or what's going to happen.
Right. And again, there could be, maybe some even uterine underlying issue that you don't even know about. For example, a topic that's come up a lot recently in the IVF community is reproductive immunology. And that means where your immune system, there's something going on in your uterus that's causing maybe your body to attack the embryos, or there's something going on that's causing your uterus to not be a good environment for implantation. It could be not even something immunological. It could be something like a bacteria imbalance. It could be something called endometritis, which is where you have a chronic infection in your uterus. And you might not even know that you have these things. And so, again, why use two embryos if you have something like that going on that you don't even know about and then lose two? So I always say if it's your first transfer, I'd only do one. If things don't work out, then explore your options about what can you do to maybe have a successful transfer in the future. But try not to lose hope after one. It doesn't necessarily always mean that there's something wrong. Sometimes transfers just don't work for one reason or another, and there might not be any signs to back it up. It could just be something that happens. So don't always feel like if you don't get pregnant on your first try that it'll be a failure in the future. That's not always the case.
Is there an amount of cycles that generally you will see success after?
I would say if there's no underlying issue, so let's just say that we can't figure out why someone's not getting pregnant. They transfer a good embryo, it's genetically normal. They've done a uterine biopsy to see if there's any kind of underlying uterine issue, and like they just can't get pregnant. And you're like, I don't know why. I would say that I would expect to see maybe after 3 transfers at most is when I would probably see some success. Now, by success, I mean implantation might occur. It doesn't always necessarily mean that a healthy pregnancy will occur. For some, even just having implantation occur is a step in the right direction. It means that something somehow is going right that is causing at least implantation to occur, and then you can move on from that at least. But at least it's successful in terms of getting pregnant. Now you just have to figure out the next step for maintaining the pregnancy.
Yeah, going back to the sort of transfer things that we were talking about, if you had to freeze the embryo because you just weren't ready that cycle, how long can you freeze for? Is there a due time?
Indefinitely. No, they can be frozen indefinitely. Actually, at the clinic I worked at, we thawed an embryo from the early 2000s, I think, and it thawed just fine. Now, there are studies that say the longer that they're frozen, the poorer their quality will be post-thaw. I think it was the lower success rate they might have the longer they're frozen. I don't know all the data for that, but I know that I've personally seen great embryos from 15, 20 years ago. So indefinitely, in my opinion, I would say they can indefinitely be frozen.
And do you know of anything that can kind of boost a successful implantation or a successful transfer? Is there anything that the woman can do or the man can do to kind of boost their fertility?
Yeah, it's a question I get asked a lot, and a lot of that leads back to there are two things at play with any transfer. There's the embryo and there's the uterus. So to get an embryo, you want it to be good in appearance. So you want it to have all of the right parts that look good, and you want it to be genetically normal. So for that to happen, you want to have good sperm and egg quality. And so that comes back to, how do you improve egg and sperm quality? Scientifically, they say there's no way to really improve egg quality because women are born with all of the eggs that they'll ever have, meaning that really a woman's egg quality declines over time. So there are some, supplements or lifestyle changes. There are some things kind of out there in the world that people say can improve egg quality, but scientifically speaking, there's really no way. It just, as we age, our egg quality tends to decline, sometimes even before some women, it declines earlier than it might for others. But you can certainly, maintain a healthy lifestyle. And actually, the same goes for men, although men produce sperm constantly. So it actually is possible to improve sperm quality, but it can take 90+ days to do that, because it takes about 90 days for sperm production to occur. So if you start making changes, you want to wait at least 90 days before you start actually seeing how those changes take place. But for egg and or sperm quality, ways to improve it are, maintaining a healthy diet, a good exercise routine. There are supplements out there that have shown improvement. Avoiding tobacco, excess alcohol, trying to avoid stress. All the things that people are basically like, do on a normal basis to stay healthy, like eat right and exercise well and take your vitamins and don't smoke. So really, it's kind of all the same thing there. Some women have said that acupuncture has helped as well. Red light therapy is something that also kind of comes into play. Again, there's not a lot of scientific evidence to back those up, but I hear, through the grapevine. So, but those are ways to kind of improve your egg or sperm quality, which can then hopefully improve your embryo quality. The other thing is the uterus. So you want to make sure that the uterus is providing a healthy environment for implantation. So you want to make sure that there are no major fibroids or polyps or scarring. So again, that goes back to sort of the hysteroscopy, if needed, to kind of look into the uterus and see if there's anything abnormal that could be interfering with implantation. There are tests out there that can determine what kind of bacteria are in the uterus. I don't know that all of these tests are necessary right off the bat, but they're things that you can look into maybe if you're having failed transfers. And they can tell you what kind of bacteria are present. Is there too much bad bacteria? Is there an infection? Is there something immunological going on? So those, having all of those boxes checked off are probably the best ways to kind of improve your chances of success. But again, I wouldn't jump on all of those right off the bat. I would maybe just wait and see how a transfer or two goes before you dive into those, because they can be costly and time consuming, and they're not always necessary.
Yeah, and it's a lot of needless kind of stress and all the things that you want to kind of avoid.
Yeah, it's stressful enough as it is. So
yeah, it sounds like we already know what to do. We just have to do it.
Yeah, sometimes it just takes an event like infertility, unfortunately, to be like, okay, well, you know what, maybe I need to really start exercising more. Maybe I really do need to watch my diet. Maybe I should be taking a vitamin or talking to my doctor about supplements that maybe I could take. Or sometimes we lack on it until we need to do it.
Exactly. I've heard of this thing called day 357 transfer. What is that?
So the day refers to how old the embryo is, basically. So we consider, in the IVF lab, we have sort of a 7-day cycle. So day 0 will be the day that the embryo or the eggs are retrieved and insemination occurs. And then from there, you move on to day 1, day 2, day 3. So on day 1 is normally when we check for fertilization to occur. Some clinics will do transfers on day 3. So that means, Fertilization checks on day 1, you let the embryos grow on day 2, and then on day 3, you do a transfer. At that point, the embryos are still cellular. They haven't quite developed into that, picture of the embryo we see that has like the big cavity in the middle. They're still cellular at that point, but a lot of clinics will transfer. Well, not a lot of clinics. Some clinics will transfer on day 3. It's kind of becoming less common, but clinics still do it, and that's perfectly fine. So that would be day 3. Other clinics will wait another 2 days before doing a transfer or looking at the embryos or doing a biopsy or freezing. So that's where you get the day 3, day 4, day 5, and some clinics will even culture all the way up to day 7. It basically tells you how old your embryo is. Like I have an embryo that's 7 days old. Yeah.
Some of these terms you sort of look at, you're like, what is that? But yeah,
right. I know. IVF comes with a lot of terms. It comes with a lot of acronyms and abbreviations, and yeah.
With that, like how long can you wait with a fresh embryo? Is it the 7 days? Is that the most?
I don't know of any clinics that will culture after 7 days, and I think that has a lot to do with the environment that the embryos are in an incubator. The media and the environment that we have for the embryos at this point in time doesn't really allow for them to grow past that point. We're not able to give them what they need to continue to grow. And so what you'll notice is that embryos do tend to degenerate after that time in culture. But we're getting better. Not so long ago, embryos only made it to day 3, or before that, they basically got fertilized and transferred. So the science is getting better, but as of right now, 7 is the most I've ever seen.
Is it set up so the woman comes in on that 7th day, and that's when transfer happens?
Most transfers actually occur on day 5. So some clinics will also do it on day 6. I don't actually know of any that do day 7 transfers, although there could be some out there that do, but the majority of those fresh transfers will occur on day 5.
Yeah, because I'm guessing it's more risky to wait that long, like if we haven't got the technology yet.
And yeah, and it goes a lot with the timing of the menstrual cycle and the medications and the uterine thickness. And there's a lot of timing that goes into everything as well. And day 5, I think, has just been shown to be the most successful.
Yeah, and obviously the freezing, when does is the freezing the same? So like on day 5, or do you freeze earlier because you would know already that they're going to be frozen?
Most freezing actually occurs on days 5, 6, and 7. So let's just say that it's day 5 and you have an embryo to transfer. That's awesome. We can transfer that embryo. But if you have another one too that's also met specific criteria to be frozen, we can freeze it on that day. If not, we can let the embryos grow another day or 2 and we can freeze them if they're ready.
Right. So you have set criteria for how far along the embryo has to be in order for then the process to move on.
Right. So embryos have to be at least on days 5, 6, and 7. So on day 3, there's a whole separate grading criteria, but I won't really go into that because again, I think the majority is day 5, 6, 7. So we're looking for 3 criteria when we look at embryos on days 5, 6, and 7 in order for them to be transferred or biopsied or frozen. So we want to make sure they're at the right stage of development. So I know I talked about how that embryo kind of has like that big cavity in the middle. So what you'll notice is that there are a couple different parts of an embryo. It's surrounded by a shell, and then it's got a clump of cells that kind of sit off to one side, and that's called the inner cell mass. That's the part of the embryo that'll become the baby. And then there are cells that line that shell, and those are called the trifectoderm cells, and they'll become the placenta. So we want to make sure that the embryo is at least at the expanded blastocyst stage, and that means that it's grown so much that the shell around it has actually started to thin out, just from the pressure of the embryo growing inside. So that's when we would call it an expanded blastocyst. And then from there, what happens is a hole actually starts to form in the shell from that pressure, and the embryo actually will start to hatch out of that hole. And then it'll fully hatch, and that's what it needs to do in order to implant into the uterine lining. So an embryo that isn't hatched won't be able to implant because that shell is in the way. So it's important to make sure that the embryo is at a certain stage of development, or clinics can do what's called assisted hatching, where they'll use a laser to make a little hole in the shell to help the embryo hatch. Right. And that's usually done before transfer. Yeah, so I mean, you want it to be at least at that stage of development, and then you want that inner cell mass to look a certain way. You want it to be pretty compact. You want it to have enough cells, because if not, then it has a really low chance of resulting in a healthy pregnancy, because again, that's the part of the embryo that will develop into the baby. So if it's not there, or it's, very scarce, it has a very small chance of resulting in a healthy pregnancy. And the same for those cells that become the placenta. If there aren't a lot, or if they look abnormal, or there's just something, maybe they're degenerate or something, you don't want to transfer that embryo because it has a really low chance of implanting.
I was gonna just ask you a couple of sort of questions about egg quality and like age. There are some women who go through menopause quite early, and so in terms of recommendations, would you recommend them just saving as many eggs as they can, or going through some cycles where they actually do have a transfer?
That's a good question. And unfortunately for women who go through menopause early, they don't often do well with IVF. They're lucky to get a couple of good quality eggs. They're lucky to get a couple of good quality embryos. So it's hard, because if you don't know that that's going to happen, I would honestly say, freeze your eggs while you're young. And that way, if you do go through menopause early, or you have some kind of ovarian insufficiency or something, you'll have those eggs that are frozen from when you're younger. But of course, women don't always know that they're going to have this insufficiency or go through menopause early. So that's not really a valid answer. I would say that if that's the case, maybe try to do a cycle or two and see how many embryos you have. But I also think that if you're planning on doing IVF for any reason at all, whether it means that you are waiting to start a family, you just want to have some embryos, it's always good to just bank them. And that means that you might do a couple of cycles and have a couple of embryos frozen from different cycles. And that just gives you more options down the road. So I think if, you're going through the process of having this insufficiency or having early menopause, the sooner that you're able to either freeze your eggs or freeze embryos, the better.
Is there anything that impacts IVF, like in terms of the effectiveness of it, or actually going through the process of it?
I think that all, again, sort of comes back to those lifestyle factors. There are situations sometimes where women maybe don't they don't respond well to the IVF medications. And in those situations, what we notice is that maybe not a lot of eggs mature, maybe not a lot are retrieved, maybe they're abnormal, they don't fertilize well. In those cases, if you were to come back and do another cycle, it might be possible to change your medications to maybe get a better result. But really, the main thing to do to affect it is, again, to just try to maintain that healthy lifestyle and follow your doctor's orders. Maybe your doctor might know something about your history that could change your cycle, but generally speaking, it would be the same things that we talked about for improving egg and sperm quality.
Now, if you're going through IVF and it's just not working and you're not reacting well with the treatments, are there any other options for you in terms of getting that sort of medical help to have a baby?
Absolutely. So there's a lot of third-party options, and that means when you bring in any kind of donor, whether it be a sperm donor, an egg donor, an embryo donor, there are definitely those options. So say you have some kind of egg quality issue where you do have that early menopause or that ovarian insufficiency, and you just don't have any good quality eggs. They're not able to retrieve them, or they're not mature or normal. You're not making embryos. Maybe you could use donor eggs. And so though the child might not be genetically related to the mother in that case, you could still use the partner's sperm. So there could be some still genetic tie to the parents. And those egg donors can be either from like an egg bank, or some clinics also have anonymous donors. They could also be known donors. Say it's a situation where for one reason or another you're not making eggs, maybe a friend could donate theirs to you as well. So that's something to consider. And the same goes for sperm. Say that you're making a lot of good quality eggs, but the sperm sample, just no matter what, it's just poor in quality or low count, whatever it might be. You could use donor sperm. And then same with embryos. If you just, for any reason, maybe it's an egg and sperm issue, or for any reason you're not making embryos, there are also embryo donation programs out there as well that you could use. And the same too, even if you're making embryos, but you still aren't able to get pregnant, you could look into a gestational carrier or a surrogate. And that's if you have multiple failed transfers, but you're making good quality embryos and you can't figure out why they're not implanting or why you keep miscarrying, you might consider looking into a gestational carrier or a surrogate to help you achieve a pregnancy.
And I mean, obviously the process with a surrogate would be very different, but is the process with a egg donor or a sperm donor, is that any different from sort of if it was your egg?
Not really. No, the main difference is that the eggs and sperm often come from banks, so they're frozen. And so the main thing would be that they just need to be thawed rather than retrieved. And I mean, you can also have your own eggs thawed, even, so it would be similar to if you had your eggs frozen, they would have to be thawed before they're inseminated. So that's the only main difference really, is that they have to be thawed first before they're inseminated. Other than that, they're treated just like eggs would be if they were retrieved from you. Mm-hmm. And sperm too.
Is that thawing process long, or is it?
No, the thawing process only takes roughly 10 to 15 minutes to complete.
Oh, wow. So it's not like thawing out some chicken.
Right. No. Only a couple of cells we're dealing with. So it's actually a really fast process, but it's a very specific process because you want to make sure that you're safely thawing those embryos back to room temperature from, negative 196, I think, degrees is the liquid nitrogen. So
not quite like chicken. Not quite like
no. No, but I mean, thawing is, kind of the same process, just a little faster.
Yeah, I had a little look into how much it costs to like save eggs and save sperm, and wow, I was just amazed. But obviously there's so much that goes into it, and they have to continually keep those machines going to keep them at the right temperature. So yeah, that's a whole nother thing.
Yeah, the whole process is so expensive, but yes, those tanks they're expensive and they have to be constantly filled and monitored, and they're pretty well regulated, so there has to constantly be someone a lot of them are hooked up to 24/7 alarm systems. So there might be a time where I know I've gone into the lab at 3 a.m. on a Saturday because one of the batteries died. And so someone had to go in and change it. So it is, it's expensive, but they are, I don't want to say they're a lot of work, but they're in constant need of monitoring, basically.
Yeah. Much like a baby.
Oh, yes. Yes, absolutely.
Yeah, so it starts from egg, people. Starts from egg.
We always call ourselves the early babysitters because we're the ones who just kind of, we kind of watch them until they're ready to move on.
And it would be really odd if we sort of like end up with more sort of knowledge about this process, and then like we find out that there's like I don't know, like the egg nose or something. I don't know. There's some weird stuff that can happen in real life.
I mean, technology's always changing. You never know.
Is there anything that you wanted to tell our sort of audience at all before we go? Because I know we said an hour, and we're close. We're at that time now. So
the main thing that I would say is, don't be afraid to reach out to your doctor and, advocate for yourself. I think that's really important. So if you have questions about your treatment or your diagnosis or something, always ask your doctor. I think that that's really important, that you know why you're at an IVF clinic, why you need IVF, what your options are, and use your resources. I know we talked about my page. I think that it's really helpful for a lot of people, but there are so many excellent resources out there for you to help you make good decisions about your care, because it's a really involved process and it is very stressful. So use the resources that are out there, use the community of people out there who are always more than willing to talk and help. And I think it will make the process a lot easier. And other than that, no, feel free to ask me any questions. If you go onto my Instagram and you see anything, feel free to ask questions. I'm always happy to help if I can.
yeah, wonderful. And we'll link some of that stuff down the bottom as well, like your I think you've got a website as well. So we'll link that.
I do.
Yeah. And then, yeah, if you've got any sort of pamphlet type things or information that could be helpful, that you believe would be helpful, yeah, just send me the links and I'll link them down the bottom, because then people can kind of like have a look at that too. Because I know we didn't really cover like everything. There's so much more to IVF, but
There is.
we at least gave the beginnings and sort of got to that transfer moment. But yeah, there's a lot more involved, and yeah, and you are full of knowledge from having helped many women, I'm sure, have their lovely babies. So thank you for what you do and for helping women have their families. And we hope it continues, and we hope there's many more babies to come into the world through this process, and hopefully we'll get more like better science.
I know it's getting better. It is, but it'll get there, hopefully.
Well, thank you so much for coming and talking with us, and being part of this event. It's been so amazing to have you, and I've loved our chats, and hopefully you'll be on the live event as well.
I'm hoping. I'm hoping to.
Wonderful.
Yeah.
So hopefully that will go well, and yeah, we'll see you then again, and yeah, we can talk more. I'm not sure how much more we can get into it, especially because this was a whole hour and we only talked up to transfer. So
well, yes, let me know. I'm always happy to I love talking about it, so anytime.
Thank you so much.
Of course. Thank you very much.
Yeah. If you're happy to do another one of these to then go into the second half, then yeah, I'm totally up for that, if you're up for that, because then we can kind of like go into that. I'm not sure how much more information you sort of go into or what you do, because obviously
I'm trying to think if it definitely probably wouldn't be another hour. Really, the main thing that we haven't really touched on is PGT, but to be honest, a lot of countries don't do PGT anyway. So I don't know that it would be,
well, then we probably,
I mean, I was going to say I'm happy to talk about it, but yeah, that's completely up to you. But really, other than that, we've touched on a whole lot of pretty much what we do in the lab. Yeah.
Yeah, because I was like, yeah, I don't think you do any more than, like, you do more, but like you don't. Yeah, that's the sort of process, and then it's kind of done like ish. I know there's and things, but
a lot of charting and
yeah, you've done your babysitting. Yeah. I was like, is there more? I don't know. What's that thing that you said? The
PGT, it's a pre-implantation genetic testing. And what that means is that you take about 5 to 10 cells from an embryo and you send them off for genetic testing. And what it does is it can tell you if those cells have the right number of chromosomes. Right. And in certain situations, like if you maybe have a genetic disease that runs in your family, or you're a carrier for a genetic disease, some of those diseases can be tested for as well. So it can determine if the embryo is affected by the disease, or if there's if a lot of the cells have the right number of chromosomes, and that in turn can predict the success rate. So genetically abnormal embryos have a very low chance of implantation and a high chance of miscarriage. So those are typically not allowed to be transferred, where genetically normal embryos have a high number of normal cells and they are recommended for transfer. They have a high success rate.
Yeah, so again, that's like pre-transfer anyway. So yeah, so you handle sort of from retrieval to transfer, and then do you handle anything after that, or is that's it?
Well, we would do the frozen transfers as well. So, we have those 7 days of the fresh cycle, but then we also have later down the road, we have the thaws and the transfers.
Yeah, gosh. Yeah.
Yeah.
I'm just amazed. Like, there's just so much involved. I didn't, like, you don't think about it because everyone's just like, oh yeah, just get IVF. So you just don't.
I'll just do IVF.
Yeah, and then there's like amazing women like you spending all this time like in a lab and like, making sure these babies like happen, and it's like yeah. But
it's a great job. I love it. But it's a stressful job. I mean, you are constantly on alert. You can't mix up anything. You can't drop a dish. You can't mix up anything. I mean, that includes writing the wrong number on a chart. I mean, everything is so specific, and which is good because what's that?
life is on the line, literally.
Yes, exactly. Yeah. So it's a high stress job, I will say that, but I do love it so much. I think it's one of the coolest jobs you could have. So
I think like you said, like you had a hard time with pregnancy in our last conversation, and like because you know all the things that can go wrong, and obviously having a baby, you're just like, you know, you're making this happen for so many women, you
it's
know.
amazing. Yeah, my pregnancy was I luckily everything she was very healthy and she's a great 1.5, almost 2 year old that I have running around. But yeah, I remember from the moment that I had my blood actually tested at the clinic I worked at, and my friend was the one who drew it, and she was like, "Hey, congratulations, you're pregnant," and I was like, no, I'm not. Like it can't, it's not that easy because, you see it every day. You see women who are trying to get pregnant and they can't for one reason or another, and then the whole time I'm just sitting there like, well, when's something going to go wrong? Like you just have it ingrained in your head from seeing women who are coming in who can't get pregnant or who are miscarrying. And I think after a while, it sort of messes with your head a little bit that you're like, all these women, these women are struggling, and I'm sure I am too. And when's something going to happen to me? And I it was nerve wracking. I mean, any pregnancy is nerve wracking, but
Well, I think a lot of women like have the opposite kind of problem until it happens, and then they're like, "What? This happened to me? But I thought I
that is
wasn't going to be this woman," you know. And I think, yeah, I mean, there's pluses and minuses either way. Like freaking out while you're pregnant's really hard and stressful, and just, you know, because I'm pregnant right now after having 2 losses, so it's like very harsh. But at the same time, I feel a little bit more kind of centered knowing those things that can go wrong. And
Mhm.
it's odd. Like I'm terrified, but I also, you know, I feel like there's another understanding, and like I'm prepared in a sense.
Yes, I totally understand what you're saying, and congratulations.
Thank you.
But
Yes, 2
yes, I
weeks.
completely understand. It's like knowledge is power, but ignorance is bliss almost. Like it's
Yeah.
good to have that knowledge base and those tools, but at the same time, it causes a lot of maybe unnecessary stress, and you just sort of you're almost like you're waiting for something bad to happen, pretty much, and you hope it doesn't. But
Yeah.
yeah.
It's like you said with the IVF, like do a cycle and then do the testing if you have if something
Hmm.
going right, because otherwise you could be needlessly like freaking yourself out. You could find
Hmm.
something wrong, but then it could be successful anyway.
Right, exactly.
That's,
I agree. And
yeah.
that's why when people ask me, should I do this? Should I do this? And I'm like, have you had failed transfers in the past? And they're like, well, no, I don't think so. And I'm like, I wouldn't personally. I mean, I'll never tell a person what to do. It's your body. I do whatever you want with it. But I just don't know that it's always necessarily worth all of that time and money and yeah, unnecessary stress waiting for those results. And yeah, so that's just
Yeah,
my
when you
two
were
cents on
saying
the whole thing.
Yeah, when you were saying about it, it kind of reminded me about like actually being pregnant and like having the baby. Because I was like, the first one, I was like, we're going to have it in the hospital because I have no idea what to expect. I have no idea about anything. And I wanted a home birth, but I was too scared because I was like, well, I don't know what my body's going to do. For the first one, we had a hospital birth. And then the second one, we had a home birth because I
Mhm.
knew what to expect. I knew what I was going through. And I think it's the same with IVF. Like, go through one cycle so you know the process, so you understand and you can see what your body does, and then
Mhm.
then you know what your body's going to do, if you're going to get bruising, if you're going to get side effects, if you're going to be fine, if your body's going to actually respond. And then
Mhm.
if it does and you get a baby, fantastic. If not, you've got other options, and you can work through those. It's great that there's so many different options as well. Like I know we
Definitely.
discussed IUI in our conversation before this event, and that was I had a little look into that, and it was quite interesting, like that it goes
Mhm.
along with you and your actual body. So yeah, it's quite interesting.
It is. It really is. Yeah. The whole thing. Yeah, it's definitely interesting for sure.
I don't think I could do your job though. Too high stress. I'm clumsy. I'm so clumsy. I'd just drop it, and then I'd be like, "Oh my gosh, that's someone's baby!" Like, no, no.
You could do it if you really tried. There's a lot of training that goes into being an embryologist. I mean, they don't just stick you on the scope the one day and be like, here, get these eggs. So there's a lot of training.
It's not like being a mum where you have the baby and like,
yeah, they pretty much hand you the baby. You're like, what do I do with this thing?
But they're they can handle a bit more than an embryo in a.
Yeah, they're resilient.
They bounce back.
Yeah. Exactly.
Well, thank you again. Thank you so much for speaking with me and doing this little bit extra, because now I can kind of like put this in there as well.
Sure.
It's been lovely, and I'm sure so many women are going to find this so helpful, because like I said, some women don't even realize this is an option. Some women are confused because there's so much information about IVF, and you're like, where am I going with it? Because obviously, like you said, different clinics do different things, so then you're kind of in this too much information. Where is there misinformation, or is it
Well, and that's the problem. If you go online and you kind of go down a rabbit hole sometimes too of information that's on the internet that's maybe not all accurate, or some of it is maybe personal anecdotes or something, and that can be really harmful for some people. So there's a lot of information out there.
It's a there's not a lot of pregnant.
Yeah, exactly. Or there are a lot of superstitions out there. There are all kinds, but there's not a lot of education. I mean, it's there, but it's lacking. So a lot of information, but maybe not education, just information or misinformation even that is readily available.
Yeah, I think the main thing is just like IVF doesn't equal a baby. Like you have to put that in your mind. As much as we want to say, yes, IVF will give you a baby, can't say that, because you don't know, depending on the woman, right? So it's every woman just needs to know that, if you do go through this process, it's not guaranteed. It could help and it could happen, but it's not guaranteed, and for some people it doesn't work, and that is sad. But we can't expect
realistic.
We can't be like, we're definitely having a baby now. I
wish that would make my job a lot easier, but
surrogates, like, because I was like, oh yeah, you get a surrogate, right, baby, but even surrogates can have losses, and and that is just devastating, because like you've gone through yourself, you've gone for the surrogacy, and then another loss. So it's just, so you're not guaranteed a baby at any point, but it does sort of bring up your chances, because you guys do look after your patients so well in terms of like the treatment and the keep the hormones and monitoring. So it's really really awesome to hear that, and I'm so glad there's women like you working in those clinics, because you just seem so lovely and wonderful, and
thank you.
So glad that you're helping women do this. So thank you very much, and I can't wait to speak to you again and do the live. I'm not sure which one we're going to do together, but I'm sure I'll be doing that in the next week anyway, so I'll send that to you when I've got it all figured out, because there's a lot of different people saying yes, this So,
well, don't forget to focus on yourself too. And what you're doing is awesome, but it's got to be stressful. So.
Oh yeah. I've had some downtime. It's all good.
Okay.
It's got to be systems go now.
Okay. Well, you take care of yourself.
You too. Bye.
Okay. All right. Take care. Bye.
Please note that all speakers, including experts and professionals, express information, views, and opinions that should not be used to diagnose, treat, cure, or prevent any medical conditions. If you have a medical issue, please consult a qualified professional. Speakers voice their own views, opinions, and conclusions, and they may not reflect the views, opinions, and conclusions of other speakers. Ella Rose, The Joy of Sunflowers, and its sponsors may not endorse all or any of the views, opinions, or conclusions expressed.